Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Thank you for joining me here today. This will be the first of a three-part series in which we will discuss the role of the radiologist and the nuclear medicine physician in supporting the treatment of Alzheimer's disease. Now, let's just take a moment to set the stage for our topic today. At this point in time, we are at a pivotal moment in the treatment of Alzheimer's disease. As many of you know, the FDA has just approved the first ever drugs in the treatment of Alzheimer's disease, which are the first quote-unquote disease-modifying agents, meaning they actually change the trajectory of the disease. Now, many of the drugs you may have heard of to date for Alzheimer's disease treatment, such as Medicin or cholinesterase inhibitors, are simply for symptomatic relief, not treatment in terms of altering course of disease. So with this new class of drug we're talking about, there's actually a palpable excitement that progress is clearly taking place in our ability to slow the mental decline related to Alzheimer's disease. Now, today our aim in this talk. In this particular talk, we will discuss the underlying pathophysiology of Alzheimer's disease to gain insight as to why and how we as imagers will play a vital role in this new treatment. Now, for starters, this slide captures the sweeping global burden of Alzheimer's disease. The numbers, as you can see, are truly staggering. The interesting thing is the prevalence of Alzheimer's disease actually increases exponentially with age, more than doubling with each decade from age 65 to 75 and 75 to 85. And the impact on society is truly profound, with the economic and especially emotional toll it extracts on the patients, their families, societies, caregivers. The effects are extreme worldwide. Now, in this slide, we're looking at the leading causes of death in the United States. And this slide nicely contextualizes that Alzheimer's disease is not just a neurodegenerative disease that we tend to think of it as being, but it's actually one of the most lethal diseases in the United States, typically accounting or ranking in the top 10 of leading killers, oftentimes getting close to the top 5. The interesting point is, as I outlined, all these other conditions such as heart disease, cancer, diabetes have had disease-modifying agents for decades. However, not for Alzheimer's disease. That's why this is such a big step in the treatment of Alzheimer's disease, namely the approval of these new agents. Now, in this graph, what we're looking at is basically the map of biological cascade of Alzheimer's disease, showing how things such as amyloid in the red, tau in the green, or synaptic dysfunction in the yellow precede the onset of clinical symptoms by decades. So in this graph, what we're looking at on the x-axis is time, and the y-axis is actually the magnitude of the biomarker. And we see that things such as amyloid actually accumulate literally decades before the onset of clinical cognitive dysfunction. So our goal is to try and identify these individuals in the early stages of disease, and using a variety of tools to find those individuals to try and actually get them to treatment. Now, I wanted to touch on the diagnostic tools we have for Alzheimer's disease diagnosis, and it falls into several domains. Now, the first two are referred to as liquid biomarkers. They're both blood and CSF biomarkers, and many of these are very cutting edge and new and are valuable in prognosticating the probability of patients developing Alzheimer's disease. Now, on the next slide, we're showing the categories that we're more familiar with, the imaging-based diagnostics, and then finally the clinical, cognitive, and functional testing tools. So the bottom line is, at this point in time, we have a very comprehensive diagnostic armamentarium to find these patients at an early stage such that we can intervene with these new agents. Now, I just wanted to show an example of a typical amyloid PET scan. On the left, we have the negative baseline. So this is what a normal patient would look like. These tracers, the amyloid tracers, typically will bind to the deep white matter and gray matter structures, not the cortex where the amyloid is located. So in a negative scan, you have a study that looks like this, when in fact you kind of have a gray-white differentiation, and you can see that there's not take-up in the periphery. However, when it's positive, what we get is basically the filling out of the brain. We lose that gray-white differentiation because the isotope is being taken up in the cortical gray matter as well as the leptomeninges, and it fills out the pattern. Now, of course, positivity is a spectrum going all the way from this absolutely normal to an absolutely positive scan. So that's the amyloid PET scan. The next slide is showing us the tau PET scan, and we can see a negative study on the left. Usually there's a fair amount of uptake in soft tissues, the skull base, leptomeningeal structures, but not the brain. In the positive scans, we tend to see the uptake primarily in the temporal lobes, especially the hippocampal and parahippocampal structures. And you can also see some extra hippocampal involvement, oftentimes in the frontal or parietal lobes. Now, this slide is quite interesting because what it shows us is the interplay between positive amyloid and tau scans and how this pathology really sharply stratifies the risk of clinical progression. So what we're looking at is the odds ratio of developing dementia. If you have a positive amyloid scan that we just saw, for example, but a negative tau, in either of these cases, either normal cognition or MCI, mild cognitive impairment, there is a two-fold increase in the likelihood of developing dementia over a normal. However, if the amyloid and the tau are both positive, you have over a 10-fold increase. So this strongly highlights the predictive power of these biomarker-defined stages in Alzheimer's disease. This is an interesting example just to show you the power of these agents. This is a patient who's been treated with an anti-amyloid agent. This was their starting scan at baseline. And I know the images are small, but you can see that there's kind of a homogeneous gray, lack of gray-white differentiation. So homogeneous enhancement of the entire brain. This would be a 10 out of 10 positive. The patient was scanned 5 subsequent times in the ensuing 52 weeks. And by the end of the year, we're back to an absolutely normal scan. So progressive removal of amyloid. And by the end of the year of treatment, we have a scan that basically has 0 amyloid with the characteristic classic picture of a negative PET scan. Now, there's a whole host of anti-amyloid immunotherapies that have been developed over the years. We started over 20 years ago with bapineuzumab. And so there's a whole host of them. We have the 2 that have been approved, and there are even more in the pipeline. In this slide, I wanted to show that the therapeutic landscape of anti-amyloid immunotherapies really targets different parts of the amyloid plaque formation. So you start with formation of the amyloid, soluble monomers and oligomers that then aggregate to fibrils and plaques. And you can see the 2 more recently approved agents, they're working on more of the fibril and the plaque formation removal. So this is basically giving us a sense that these different agents target different aspects of the amyloid. Now, this is some of the early data, and this was the initial foundational proof that amyloid burden can be visibly or qualitatively, as well as quantitatively, removed from the brain and measured. And so these were the first studies in humans showing that we could visibly remove amyloid from the brain. On the left here, we have baseline patients treated with either placebo, 3 mg per kg, double that or 10, and we can see visually the qualitative removal of amyloid using PET scan. Then we can take a look on the right. We have the graph showing the quantitative removal, where you can actually measure in SUVR the removal of amyloid and showing that more drug typically will remove more amyloid. Now, in these pictures, we're looking at actual photomicrographs of the vessel walls in patients with Alzheimer's disease. And what we can see is the bright red represents the actual amyloid within the vessel wall. And in these examples, you can see how much of the vessel wall is actually made up by amyloid with the displacement and the removal of smooth muscle. So as a result, you have vessels, depending on if you have more amyloid deposited, your vessels are their wall have more amyloid constituting the structural integrity of the wall. Now, this is important for us to understand as imagers, because understanding this amyloid forming a structural basis for the vessel wall is going to tell us a lot. It's going to give us the who, why, and where and when of why complications occur. So, for example, it's going to tell us who's eligible for treatment, why complications occur, who's at risk for developing these complications, and when will these complications occur. Now, let's take a look at the consequences of this vascular clearance of amyloid. We discussed how immunization with these anti-amyloid agents results in the removal of the amyloid from the vessel wall, reducing its structural integrity, leading to the extravasation. So in other words, as we remove amyloid, these vessels become more permeable, leading to leakage of fluids and sometimes even red blood cells. And this is the consequence. This is an MRI scan of a patient who's been treated with an anti-amyloid agent. On the left, we have the T2 flare showing large areas of edema in the occipital lobes bilaterally, right greater than left. And on the right, we have concomitant development of microhemorrhages, these tiny punctate areas of blood product that are seen in the area of this vasogenic edema. And these have been termed the amyloid-related imaging abnormalities, or ARIA you've heard of. On the left, we have the ARIA-E, or the edematous form, which is a transient edema without any cytotoxic issues. And on the right, we have the microhemorrhages referred to as the ARIA-H. Now, interestingly, this patient was absolutely asymptomatic, as are the majority of patients who have ARIA-E. And this is why we as imagers play such an important role in the treatment of patients with Alzheimer's disease with these new agents. It's because they can develop this condition of ARIA, and in the majority of cases, it's clinically asymptomatic, which means the last thing this patient needs is more of the drug that caused this. It can be catastrophic. As a result, at imagers, we play an important role to identify these changes in the far subtler forms. We're not wanting them to get this advanced. Far subtler forms to alert the clinicians in a timely fashion so that their dosage and their treatment can be modified accordingly. And this is what leads to the concept of the importance of the surveillance imaging. This slide nicely demonstrates that the majority, over 3/4 of patients with either of the recently approved FDA agents, are going to be clinically asymptomatic when they have ARIA-E. So this is an important point for us to understand, and this is an example of the MRI surveillance that takes place during the treatment with these anti-amyloid agents. And it gives you a sense of the frequency. Now, this is duplicating 2 different agents. They each have their different surveillance pattern, which will be discussed in subsequent talks. However, it makes the point that a large amount of imaging is performed as part of the treatment of these patients. So, for example, on one of these agents, you may have 5 or 6 scans in the first year of treatment in a patient who normally wouldn't be scanned more than once, maybe for just a routine evaluation due to neurodegenerative or neurocognitive issues. So the point is, if you have one neurologist treating 10 patients with these agents, that's going to be 50 or 60 additional scans that you will see in your program. So you can imagine nationwide, this is a huge burden on the imaging system. And as a result, it's important for us to understand these changes and how we can play an important role in supporting our clinicians in this regard. In regards to the mechanism of clearance of the amyloid, the vascular clearance, we discussed how the removal of the amyloid results in the increased permeability of the vasculature. And on the right here, we've got 4 photomicrographs in Alzheimer's. In the first one, we can see the baseline state of the large amount of amyloid, which is the reddish material constituting a significant portion of the vascular wall. With treatment and over time, there's the removal of amyloid, resulting in a transient phase of increased permeability of the vessel, and that's when we tend to get most of the ARIA changes. Subsequently, there is a physical reconstitution of the integrity of the vessel wall due to regrowth of the smooth muscle in the wall. And we can see this is in this example where we have the recovery of the smooth muscle, and as a result, the patient is going to be more resilient to the administration of this agent and have fewer complications such as the ARIA down the road. Now, this is nicely depicted when we look at the Kaplan-Meier graphs. This is for one of the anti-amyloid agents. On the bottom, we are looking at the time frame of dosing, and the y-axis is showing us the probability of cumulative occurrence of ARIA-E. And what we can see as we go through the first 6 months of treatment is that is where most of the ARIA is occurring. So well over half of all ARIA is going to occur in those first few months of treatment. And that, of course, is the phase where we have the vascular leakiness with subsequent reconstitution of the wall, and the rate of the ARIA dramatically drops. As a result, as an imager, you can see knowing where your patient is in their treatment paradigm provides us some insight as to what is the likelihood and how subtle may the ARIA be that we should be searching for. Now, it is true that even after years of treatment, we still will have some patients who develop ARIA. So they're always at risk, but again, the key point being here that the vast majority will occur in the first 6 months. Now, on the left, we have a similar slide, which is the accumulation probability risk of developing ARIA. What this graph depicts is the genetic effects that can be involved in terms of the development of these complications, the ARIA. What we're looking at are a total of 4 different graphs. The red line are the non-carriers with respect to the ApoE4 gene. So the non-carriers do not have either allele as being an ApoE4, and we can see that their probability of ARIA is about half of 1%. However, if you carry just 1 copy of that gene, the ApoE gene, it more than doubles your risk for getting ARIA. Now we're up to about 12 or 13% with 1 copy of the gene. And if you have 2 copies of ApoE4, a homozygous, your risk more than doubles again, up to about 35%. So this highlights the importance of understanding which of your patients are at the highest risk of developing ARIA. And of course, it relates to how much amyloid is in the wall. So patients who have more copies of the ApoE4 allele will have more amyloid in their wall. They will be more subject to structural integrity issues once all that amyloid is removed and before there's reconstitution of the smooth wall vessel. Now, this is an unfortunate case. This is a patient who unfortunately died due to treatment. Now, the number of deaths in the last 20 years have been surprisingly few. So this was an unfortunate case, and what we can see in these pictures is the staining for the amyloid as the red material, and this patient developed microaneurysms in their vasculature leading to hemorrhage and a catastrophic bleed and demise. It turns out that this patient was a homozygous ApoE4, and this really highlights the importance of knowing what your risk is related to your patient, not only their ApoE status, but also having an understanding of where they are in their treatment paradigm. Are they in the first 6 months, or is this further down the road? So we've talked about the imager's role in this new phase of the treatment of Alzheimer's disease. And we can see that it starts with the diagnosis in terms of the amyloid PET. We also will play a role in screening which patients are going to be eligible for treatment. So patients before being treated with these agents will receive a screening MRI. And in our subsequent talks, there will be discussions on the actual role of the imager to determine what metrics we're looking to in regards to determining whether the patient will be an adequate candidate for this treatment. We also touched on the role of safety monitoring in terms of the need for the imager to be following the patient over time. And that's a critical role because before the patient is going to be dosed and the MRI has been performed, the clinician is going to be waiting for the report on an urgent basis to determine whether additional drug is going to be issued. And then finally, we'll play a role in the routine monitoring of these patients long term to see if there's good response to treatment. So finally, we get to our summary. This is clearly, as we've talked about, a new phase in the diagnosis and treatment of Alzheimer's disease. And I hope today, giving us a sense of the pathophysiology underlying this condition, gives us a sense of the mechanism of how these drugs act and how and why we get these imaging changes related to what referred to as the ARIA-E and the ARIA-H, as well as an understanding of who's most susceptible and when these changes tend to occur. And finally, the role of imagers in this setting cannot be understated. We play a vital role because there are many physicians working together to use these treatments and to effectively treat the patients. So we play a crucial role in helping to manage the care of these patients. So I'll go ahead and stop there, and we'll go ahead and turn to our question and answer session. So first question we have here is, what is the role of PET and MRI in determining the stages of Alzheimer's disease? So as we touched on, we're looking to try and find patients in the earliest phases of disease involvement where a routine MRI would routinely be absolutely normal. So we want to catch patients well before they have the classic hippocampal atrophic changes related to Alzheimer's disease. By then, obviously, the patients will be very advanced. So we're looking for the early MCI patients where a routine MRI simply plays the role of ensuring that there's no other pathologic process that may be accounting for the patient's neurologic symptoms. So that would be kind of a screening role. So another question, what is the next step if the PET scan is positive? Well, if your PET scan is positive, for example, your amyloid PET scan, if they meet all other criteria, they would be a candidate for these agents. But of course, this is a multidisciplinary approach. The clinicians making the decision as to whether the patients are going to be treated have many different tools. We talked about the blood and the CSF markers, as well as these amyloid and tau PET imaging studies. So these are simply tools that the clinician will use to try and ascertain, is this patient going to be a good fit for being treated with these agents? So if there are particular questions about the MR imaging schedule, the protocols for MRI, the protocols for treatment, these will all be covered in our subsequent 2 talks, where we'll specifically get into the details of how we actually perform the evaluation on the MRI scan and on these PET studies to assess the patients. Also, the imaging features of the ARIA-E and the ARIA-H and specific imaging protocols to optimize detection of those findings. Question pops up, does the Alzheimer's disease have a genetic predisposition? As many of you may know, it's very complex. It's felt to be the result of a wide host of genetic markers. Of course, we know the ApoE4 as being one of the most prevalent ones, but there are literally dozens of them. And then, of course, there are environmental factors, as with anything. So everything from diet to exercise to almost any environmental inflammatory stress process. But the big one we know of, which only plays a very small part of the development of the disease, is the ApoE4 allele. But even patients, obviously patients with no ApoE4 will go on to develop Alzheimer's disease. And some patients with homozygous state will not develop Alzheimer's disease. So obviously it's a much more complex, multifactorial process. So what we're doing is our best using the tools available to make these diagnoses. So last question, the role of the MMSE along with MRI scan in the assessment and differentiation between different types of neurodegenerative disease. And this is a tricky question. It gets to the basis of how do you make the diagnosis of Alzheimer's disease? The bottom line is, up until a few years ago, before having the amyloid PET, of patients with a clinical diagnosis Alzheimer's disease, meeting the Frank-Dubois criteria for Alzheimer's disease, up to 40% of them would not have Alzheimer's disease, making the point that it's a hard diagnosis to make, and it requires a lot of clinical acumen as well as the variety of tests we've talked about here today to be able to hone in to make a specific diagnosis out of the entire array of potential neurodegenerative diseases. So I will stop there, and I thank you for your attention.